All right, let's jump right in. Welcome to today's Explainer, where we're going to break down the exact step-by-step clinical pathway for managing normal pressure hydrocephalus, or NPH. We're talking the whole journey here, from that initial diagnosis all the way to long-term prognosis. We've got a lot of ground to cover to make sure you don't miss a single critical point, so let's get started.
Here's our agenda for today. We'll be hitting 6 key areas. 1. Algorithm and testing. 2. CSF diversionary procedures. 3. Potential shunt complications. 4. Endoscopic third ventriculostomy. 5. Expected patient outcomes. And finally, 6. Long-term prognosis.
Section 1. Algorithm and testing, confirming the diagnosis. The very first step in our algorithm is, of course, getting an accurate classification. You know the drill. We look closely at the patient's history, do a physical exam, and get some initial imaging. This helps us sort them into one of 3 buckets: probable, possible, or unlikely NPH. Now, if a patient falls into that probable or possible bucket without doing any extra testing, our baseline diagnostic certainty is sitting right around 50 to 61%. Interestingly, if you have a totally healthy patient where NPH seems highly probable, it actually isn't unreasonable to just proceed directly to shunting based on that alone. But let's be real, for most cases, we want way more confidence before committing to brain surgery, right?
And to get that confidence, we rely heavily on the TAP test, also known as the Miller-Fisher test. This is where we carefully withdraw about 40 to 50 milliliters of CSF via a standard lumbar puncture. It's essentially a test drive. We want to temporarily simulate the effects of a shunt, just to make absolutely sure the patient is going to respond to the real-deal permanent surgical intervention.
When this test works, it's like a giant green light. If the patient has a positive response, meaning you literally see their gait or cognition get noticeably better after draining the fluid, our confidence that they'll respond well to a permanent shunt just skyrockets. The positive predictive value jumps to a highly favorable range, somewhere between 73 and 100%. It is a fantastic indicator.
But here's the catch, and we have to be super careful here, because this test has a notoriously low sensitivity. It only captures about 26 to 61% of true positive cases. A negative response does not rule out a surgical response. I can't stress this enough. A negative TAP test does not mean the patient won't benefit from a shunt. Oh, and as a quick side note, if during the LP you find an opening pressure greater than 17.6 millimeters of mercury, you've got to pause and search for causes of secondary hydrocephalus. Though again, even that higher pressure doesn't rule out shunting as a viable option.
So what about those patients with a negative TAP test who clearly still need more evaluation? Well, we use supplemental tests to dig a little deeper. Option 1 is resistance testing, which boasts a much higher sensitivity than the TAP test, ranging from 57 all the way up to 100%, and it maintains a solid positive predictive value of 75 to 92%. If you don't go that route, continuous external lumbar drainage is another highly effective way to monitor their response over a longer stretch of continuous fluid diversion.
Section 2. CSF diversionary procedures, choosing the right intervention.
When it comes down to choosing the actual intervention, the ventriculoperitoneal, or VP shunt, is hands down our definitive procedure of choice. It is highly effective and used everywhere. Back in the day, lumbar peritoneal shunts were used a lot for these patients, but man, they come with some serious baggage. They have a known tendency to overshunt, they're super tricky to tap if you ever need to check their function, and they have this annoying tendency to literally migrate within the body. The VP shunt completely avoids all those headaches, keeping it the absolute gold standard.
Now, you really have to balance the risks when selecting the actual valve for that VP shunt. For most folks, we go with a medium pressure valve, usually with a closing pressure of 65 to 90 millimeters of water. The main reason? It minimizes the risk of subdural hematomas. On the flip side, a low pressure valve, mathematically, gives you a higher clinical response rate, so the patient might feel better faster, but it brings a lot more risk. If you place a low pressure valve, you're committing to strict gradual mobilization post-op. I mean, the patient has to be sat up very, very slowly over several days just to prevent massive, dangerous fluid shifts.
But there's an incredibly elegant alternative to this whole dilemma: the programmable shunt valve. This is basically getting the best of both worlds. Surgeons can initially set the valve at a high pressure right after surgery to safely keep that subdural hematoma risk at bay. Then, over the next few weeks, they can just non-invasively dial down the pressure setting right there in the clinic until they find that perfect sweet spot of symptom relief and patient safety. If the patient isn't improving and the imaging looks stable, you can safely try dropping the pressure a bit more.
Section 3. Potential shunt complications, managing the risks.
We have to stay incredibly vigilant here, guys, because the overall complication rates for this procedure can climb to roughly 35%. That is not a small number, and it's driven in large part by the inherent frailty of the elderly brain. The folks typically suffering from NPH are older, and their cerebral tissues just don't bounce back from surgical changes the way a younger brain would.
So the biggest hurdle we have to manage is the development of subdural hematomas or hygromas. Older patients who already have cerebral atrophy are at a significantly higher risk here, especially if you went with a low-pressure valve. These complications almost always show up with a headache. Now, while most actually resolve on their own or just stay stable, roughly a third of these specific cases are severe enough that you have to go in, surgically evacuate them, and temporarily or permanently tie off the shunt. But remember, we can proactively reduce this risk right out of the gate through that gradual post-op mobilization we talked about.
Beyond hematomas, you've got to keep a really close eye out for a few other immediate post-op complications. We're talking dangerous shunt infections, intracerebral hemorrhages, and unexpected seizures. Plus, you absolutely need to prep the patient for delayed complications that could pop up months or even years down the road, most commonly mechanical failures, like a blocked tube or a physical disconnection in the hardware.
Section 4. Endoscopic third ventriculostomy, an alternative look.
Endoscopic third ventriculostomy, or ETV, was first reported as a potential NPH treatment back in 1999. Some advocates of the procedure quote a post-op improvement in up to 69% of highly selected patients. But honestly, we have a massive scientific blind spot here. Mechanistically, it's incredibly difficult to explain exactly why this works for normal pressure hydrocephalus. ETV makes perfect sense for obstructive hydrocephalus, but for NPH, the physics just don't align. To make matters worse, a lot of the studies supporting it rely on outcome measures that haven't even been validated.
Because of that, we have to issue a pretty strong clinical warning. At this point in time, ETV should absolutely not be considered a first-line treatment for the vast majority of NPH patients. It might have some super niche applications, sure, but the VP shunt firmly holds its ground as the gold standard of care.
Section 5. Expected patient outcomes. Tracking recovery.
When a shunt is successful, the clinical response follows a remarkably predictable step-by-step sequence. Urinary incontinence? That's almost always the very first symptom to clear up. Next, you'll see noticeable improvements in their gait disturbance. And finally, you start seeing an easing of the dementia symptoms. Now, a huge thing to keep in mind is that the overall response is way better when these symptoms have only been around for a short period. As always, time is brain, even with NPH.
To help predict who will actually have that success before you ever make an incision, Black et al. Gave us some incredibly clear physiological markers. You want to look for the classic clinical triad, especially if gait disturbance is their primary issue. In fact, if a patient has dementia but zero gait disturbance, they almost never respond to shunting. Other really strong markers include a lumbar puncture opening pressure over 100 millimeters of water, continuous CSF pressure over 180, or frequent Lundberg B waves, and imaging that shows large ventricles but flattened sulci, which basically tells us there's very little underlying brain atrophy.
Section 6. Long-term prognosis. Looking ahead.
When we look at long-term care, you absolutely have to understand how comorbidities interact with shunting. Specifically, NPH patients who also have Alzheimer's disease might still see procedural improvement with a VP shunt. So, having Alzheimer's doesn't just automatically disqualify them from getting a shunt. On the flip side, patients who only have Alzheimer's disease without any actual underlying NPH did not respond to shunting at all in robust placebo-controlled trials. It all boils down to the fact that an accurate diagnosis is literally everything.
I want to leave you with this final, really provocative question. Generally speaking, most successful responders to VP shunts will eventually relapse, often after 5 to 7 great years. So when a patient thrives for years but then suddenly goes downhill, are we just watching the natural, unavoidable cognitive decline of an underlying condition, or are we actually looking at a hidden, totally fixable shunt malfunction that just needs our immediate attention? The golden rule here? You absolutely must completely rule out a shunt malfunction and subdural fluid collections first, before you ever write it off as just the natural course of the disease. Always, always check the hardware. It could literally be the difference between an irreversible decline and giving someone their life back. Thanks so much for joining me on this deep dive into the NPH clinical pathway. Keep questioning, keep learning, and I'll catch you in the next explainer.